Thank you, Mike and Laurel, for your introductions to this session. Of course, when we're talking about collaboration with other groups and other organizations, the NJR has a great number of other organizations with whom we work. Here are some of the NJR stakeholders, and you can see that there are huge numbers of organizations with whom we work very closely, but the most important stakeholders are you, the surgeons, and the surgical teams involved in both performing the surgery and in collecting the data to inform the NJR work. These are some of the collaborative organizations with whom we work, and I'm going to go through some of the collaboration and activities that we've been involved with over the last few years with some of these organizations. The BOA, of course, is one of our most important principal partners, and as such, I'll dwell on that for a short time. We have signed a new memorandum of understanding this year with the BOA. This involves a variety of things in which we collaborate and where we work with the BOA closely, including things such as the direct involvement of the NJR in the elective care review process and visits. The elective care reviews are called when there is some concern over the results of a hospital and the revision rates for either hips or knees or some aspect of the arthroplasty work in a hospital. And the data that support this sort of review all comes from the NJR, but is very difficult to interpret sometimes. And as a result, a senior clinician from the NJR, either myself or one of the other senior clinicians, will be involved in all aspects of the visits and interpretation of the data from the NJR in order to help to inform those reviews. We work in close liaison with the BOA about the production of results and the publication of results about the arthroplasty work. We do enter dialogue and have some negotiation about the interpretation of the data as well as what sort of data should be presented. And we're currently also working with the BOA and with the specialist societies to try to improve the support structure for those surgeons who have sometimes been called outliers, but who are probably better referred to as having negative variants of the results of their NJR arthroplasty data. For the last 2 years, in particular, we've been working with the BOA on the musculoskeletal registry development, and I'll go into that in quite some detail because it's very timely and important at the moment. This development started really with the Taurus registry project, instigated 5 years ago by the BOA for existing and developing T&O registries, where it was felt that it would be better for them to have a governance umbrella provided by the BOA or in some other way. Then 2 years ago, the BOA requested the NJR to consider supporting a feasibility study for some of the registries to come within the NJR governance umbrella. And several of the T&O registries were keen on this and have worked extremely hard along with the BOA with the NJR and management consultants to produce a formal plan for an MSK registry across the country. This plan was submitted to the NHS Medical Director and to senior members of the NHS executive and NHS ex-executives. The MSK registry that we devised was deemed a worthwhile project by pretty much everybody that we presented the plan to, but then we found that, as often is the case, funding was going to be an issue. There was also political uncertainty at the time because of Brexit and because of the general election, and we were from time to time told the old adage, there is no money left. COVID then intervened. But now, since that Baroness Cumberlege has issued a report on the safety of medical devices, and this has changed the spectrum of what we can and can't expect to do. This Cumberlege review, which is also known as First Do No Harm, was essentially, and in the first place, an inquiry into surgical mesh, but also into various types of hormonal pregnancy test and into sodium valproate treatment and the complications of those treatments in patients. The scope was then broadened to implantable devices safety in general, and the report has been highly critical of safety assessments of devices for implantation in general, and also critical of the lack of databases to track and trace patients who have such implants, and particularly critical of the lack of outcome data to allow safety assessments to be achieved for all devices. This First Do No Harm concept has recognized that the NJR is a global leader in the field of registries for monitoring implant performance, and has also recognized that the Beyond Compliance system is innovative and it performs an essential function for the early and intense scrutiny of newly introduced devices. NHSX and NHS Digital have in fact both been undertaking parallel developments to produce plans to remedy the general lack of proper databases and registries for all devices in the NHS. And an implantable devices registry or registries will now be developed. This project has gained a great deal of impetus and traction during the last 6 months. In the early part of the year, there were various meetings, and NJR members and other key interested registry stakeholders were invited to a series of planning meetings to see how this could be achieved. In June 2020, the Implantable Devices Steering Group was established with executive level input from NHS England, NHSD, NHSX, and NHS Improvement. The National Joint Registry has been asked to consult extensively on structure and function requirements for a meaningful registry of this kind, and steering groups with heavy clinical input are now being developed for the specialist areas. There is a recognition up to the level of the Secretary of State that orthopedics has been doing a significant amount of device surveillance work for years, and we are therefore seeking within the NJR to guide and shape these NHS-wide developments due to our experience. The format of the registries is still uncertain, but it may take the form of a widespread device database, including the patients and their identifiers, to note that the patients have had those implants inserted into them, and that this information would then be more widely distributed so that registries can use that information to help inform the scrutiny of implants and, if necessary, the scrutiny of hospitals and other practice. Much of this will be under the umbrella of NHS Improvement, and of course, Professor Tim Briggs is key to that development and is a very important member of the NHS Improvement team now. We do work with trusts about the outcomes and the publication and the data that we're giving them. Trust outcomes are published online in the My NHS website. They're also published by us in the NJR annual report and published to trusts directly in their own annual clinical reports. And we've been working hard with medical directors from various trusts to ensure that the types of data, the way that we present the data, and the interpretation of all of the data provide what the trusts themselves and those medical directors want and need in order to help them in their work. Each year, this has led to some modification of the data and the nature of the presentations that we send to the surgeons and to the trusts. But if the data presented are not helpful, or if they are ambiguous, we need to know that, and we need you all to tell us. In the last few years, we've also been doing a very extensive audit. Since 2014, every NHS trust has been audited as to the data completeness. And if we find that there are missing cases where the NJR doesn't appear to have cases that do appear in the trust PAS data, or vice versa, we feed back those lists to the trusts and we ask them to correct the lists and to insert the corrected information into our database. Since 2015, that's been happening in the independent hospitals as well. This corrective audit loop has involved a great amount of work, both for us and for trusts, but it has resulted in extremely high levels of confidence in the annual data. And this process has now been automated. Some trusts are already using the automated system, and that's going to be disseminated to the rest of the hospitals in the country over the next 12 to 18 months. Beyond Compliance works closely with us, and recently introduced implants can be monitored very much more closely and in almost real time using the Beyond Compliance system. This process runs parallel to the NJR Implant Scrutiny Committee, and there is close communication about individual implants between the two systems, so that if one system picks up problems, they're able to find whether the other system has also been showing that there's a problem or concern with that implant, or whether there is not such concern. This has resulted in important new insights, not only into how the implants work, but also how their use and the way that they're used by surgeons may influence the results from an implant. For example, patella resurfacing and whether the patella is resurfaced at the time of knee replacement gives very different results depending upon the different implants. And there is detail for each of the major implants shown with and without patella resurfacing in the latest annual report, which will be coming out to you very shortly. The ODEP benchmarking system also increasingly uses data presented by implant companies and derived from the NJR. Of course, NJR data is not always generalizable to other countries and healthcare systems, but often the NJR data does give the largest sample for a given implant that's available worldwide. For different joints, the data is presented and used in different ways. For example, the whole construct is used to give a benchmark for knee surgery, for total knee replacements, whereas the hip constructs are usually assessed as a portion of the whole construct, i.e. a separate benchmark is given for the stems and for the sockets. And it's important for people to understand that, but we continue to work with industry and with ODEP to ensure that the best data is available to us when working to produce the best information for benchmarking purposes. All of the data that we use and how we interpret it is fluid, and the NJR is constantly seeking to improve the quality and the utility of the data that we give out to you. Feedback from those using the data, all surgeons, hospitals, implant companies, etc., is vital and will always be taken into consideration. The data from the NJR belongs to the UK orthopaedic community and is there to be refined and used as best we all can for the purposes of patient safety. Thank you very much for your attention.